So Professor Joe Abboud is a shoulder and elbow surgeon based at the Rothman Institute in Philadelphia, and also based a part of the Jefferson Institute. I think you were talking about the rationale for when you do arthroplasty and when is ORIF suitable. So Joe, you have the floor.
Thank you, Ali, and thank you, Ramon. It's great to be part of this wonderful panel for OrthoHub with Eduardo and Mike Gardner as well. My disclosures are in the Academy Handbook. So, why are these fractures difficult? And I think Eduardo and Mike have already talked about this. Lots of deforming forces, osteopenia, vascularity issues. It's hard to fix tuberosities regardless of what approach you're using. Maybe a little easier using Mike's approach. Healing is always a concern. And then, what are your options down the road if at first you don't succeed? I was asked to comment on this trial by my colleagues here, and I think they're just trying to set me up to sort of get smashed by the audience, because a lot of the audience here are probably fans of this trial, but I personally am not, and actually wrote a letter to the publisher at the time voicing my concerns about it. And so these were the conclusions. We're going to start with the conclusion first, which is the opposite of usual, but no significant difference between surgical treatment compared to non-surgical treatment in patient-reported outcomes at 2 years, and then follow-up study in the prestigious Bone and Joint Journal from 2016, 5-year follow-up results, no difference still in the outcomes, and of course, the cost, which I'm sure your NHS system is very interested in, is not advantageous with operative fixation. So there you have it. Everything we've talked about so far doesn't matter, correct? Wrong. So, you can make a study show any results you want, depending on how you design the study and what sort of data you analyze. So inclusion criteria involve the surgical neck. This seems like a very sort of nondescript way to describe a indication for surgery. Displacement sufficient for a treating surgeon to consider surgery. Well, that seems like a whim. And did not have to meet the NEAR criteria. Exclusion criteria. Dislocations, well, that seems like ones that you would want to include, obviously. Open fractures, okay, that seems fair not to include that. Clear indications for surgery, such as pathologic fractures, insufficient mental capacity, etc. Okay, now if you look at the breakdown of this trial, 1,000 of the 1,250 patients that were looked at were excluded. And 313 of these patients refused participation. So conclusion, 21% of these patients ended up being randomized into this study as far as surgery versus no surgery. So, and their primary outcome measure was Oxford Shoulder Score, difference of 5 points. And then they did the subgroup analysis based on things they thought that were important. Age over or under 65. Which it's pretty reasonable, but then tuberosity involvement stratifying near 1 and 2 versus 3 and 4, that doesn't make too much sense to me personally. And then looking at the numbers in each group, I think that most of us are operating on 3 and 4 part fractures, and the number of 4 part fractures here it seems to be highly underrepresented, and really the number of 1 part fractures seems to be fairly high. So again, in the 2 parts as well is very high. Surgeries, you had basically less than 2 surgeries per surgeon included in the trial. So that's concerning as well, as far as the techniques utilized here, proficiency of the surgeons, and then no radiologic assessment, which is common in a lot of retrospective studies, but not necessarily randomized control studies. So not really, convincing me that this is a well done study, and surprises me that JAMA would accept something like this. So clearly this suffers from selection bias. So you can generalize that only patients willing to be randomized to operative or non-operative treatment can you actually extrapolate the results of this study into your clinical practice. So, patients generally aren't willing to be randomized to treatment. They're relying on your advice for things as a provider. So to me, this is a very difficult study to utilize in your practice, but I'm sure as many of the insurance companies and national healthcare systems they'll reference this as one of the reasons as to why they may deny or consider surgery as unnecessary, et cetera. So suffice it to say, I'm not a big fan of this study. And so again, when you're looking at these studies and trying to decide what to do, operative versus non-operative, I think we would all agree it's a multifaceted decision: a fracture pattern, bone quality, limitations of your implants, as Eduardo eloquently demonstrated, potential concern for head viability, and patient age, comorbidities, what they can tolerate, whether they're even a surgical candidate at all, and then putting it all together. And experience matters. So, sorry. Oops. So, I look at this, I try to stratify first: younger, healthy, active, higher pain tolerance, and have good coping mechanisms versus frail, sick, low pain tolerance, low demand, elderly patients. And they're going to go into sort of my consideration for, operative versus non-operative management. Again, I think somebody with high level of activity who is going to, let's say, dominant arm with good health is going to appreciate anatomic alignment and a greater range of potential motion for their arm. So lower threshold to operate in that setting. Patient that's lower demand, higher risk patient. I think that you want to be cautious about consideration in those situations of surgical intervention, be it fixation and or arthroplasty. And when we talk about fixation, we've talked about locking plates. We've miraculously avoided intramedullary nails, but I think they're part of the discussion. And arthroplasty, which I'll try to focus a good portion of the rest of my talk on at this point. And so, Mike and Eduardo have, again, described the many failure potentials of locking plates and inadequate reductions and poor bone quality, and ending up with situations like this. And so, but you also have patients, obviously, as I was talking about earlier, who come in low demand, medical comorbidities, who have ugly looking fractures, but they miraculously oftentimes will surprise you in how they can do. And this is after it's healed, and this is the function. So this is very adequate for ADLs for this lady. She's able to get to the shelf to get to her hair and take care of her hygiene. So for this is a home run. And when we look at ORIF, we talk about the good, and we have multiple studies that support the use of plates with good outcomes, and it's been around now 10, 15 years, preventing collapse of the fracture, oftentimes showing data that's clearly better than Hemi and maybe at times better than reverse arthroplasty can give you. However, these studies start to show higher reoperation rates with complications, whether it be hardware related or screw cutout, et cetera, with these situations. So we look at these studies, and you start seeing now the sort of the bad. And this study here, looking by Gerber on 121 patients, screw cutout 57% of the patients with associated glenoid arthrosis and potential need for revision, and they are salvageable, but oftentimes these secondary operations are not as good as a primary first decision being the right one. And again, you have this, the ugly, and you really want to avoid this. And this is where clinical decision making, and if you have a situation in the OR where you're going to potentially vacillate between, am I going to be able to do an ORIF versus an arthroplasty? You need to have that discussion with the patient preoperatively, make shared decision-making decisions, and make sure that they understand what they may or may not wake up with. You don't want to have this in the immediate postoperative period and really just waste their time, increase their risk, and increase your stomach acid. And how do we know? Well, I think we know based on a lot of the things we've already talked about. But again, whether you go the non-op route or you consider hemiarthroplasty or reverse is something that I think involves a lot of training and thinking about and understanding what is going on in the field. And obviously in the last 10 years, we've moved more and more towards the reverse shoulder arthroplasty when operative indications are necessary for elderly, low-demand patients versus hemiarthroplasty. And still, I still do a fair number of ORIFs for patients who are appropriate candidates. So let's look at the evidence of what it says. When I was training and finishing up training, and even up until about probably 2010 or so, we were doing ORIF or hemiarthroplasty or as primary treatments. And I mean, hemiarthroplasty was sort of a crapshoot. You could do a great operation and they may have a decent result, or you may do a great operation and they have a crappy result. And occasionally you'd hit a home run, but they are few and far between. And so the problem with hemiarthroplasties is oftentimes you'd strike out, not just only because of the technical challenges of the operation, which is not done that frequently anymore, but also because of the variable healing of the tuberosities, which obviously dictate the function of the cuff relative to the deltoid. It's not a new concept. Grammont published on it into the 1989 and 93. Never published it, obviously, but was written about. Cazenove showed this as well. The European counterparts are always ahead of us. Cerveau in France, and then Klein, various studies showing predictable outcomes, pretty good range of motion with forward elevation, abduction of these patients. And then in the US, there's been a gradual now shift towards this for fractures that are not considered amenable to either non-operative management or internal fixation. And so the benefit of the RSA is, as we all know, is it's less reliant on the rotator cuff, and that's how it came about to be needed. Therefore, potentially fixing the tuberosities is still important and leads to better function. But if they don't heal, it's not as sort of catastrophic as it is with a hemiarthroplasty. And this has been shown in several studies now, going back to Mason's study in JBJS in 2007, looking at this in 3- and 4-part fractures. They had slightly improved external rotation in patients with tuberosity fixation. And then Journal of Orthopedic Trauma, looking at this study of just 20 patients, but still, again, reasonably good results, but not insignificant complications. Dislocations start to creep in here. Neurovascular injury is not common, but possible. Infections, acromial stress fractures, etc. And out of our group, Grant Garrigus and Luke Austin, again, they echoed similar results showing that RSA for acute fractures in the elderly outperformed Hemi, but you have to be balanced with your approach here and concerned about not only just complication profile, but also potentially the increased cost of this intervention. And this study by Derek Cuff, looking at a fairly large cohort of consecutive patients, 53 treated with Hemi versus reverse, showing better results, lower complication rates for the reverse versus the hemiarthroplasty in this cohort, published in JBJS in 2013. So, I think there's obviously guarded enthusiasm for utilization of arthroplasty, specifically the reverse arthroplasty, but these things are not insignificant complications that can happen. Obviously, we can incur complications with any operation. Some of these are unique to reverse arthroplasty, such as acromial stress fractures, scapular notching. Neurologic complications obviously can happen with any of these operations, but you have to know what you're doing. So, my approach for this is elderly patients who, have still fairly good activity level and independence, who are not going to be happy with at times waist level or chest level activity, or potentially patients who have some underlying cuff disease and or DJD prior to this happening, consideration of reverse shoulder arthroplasty. And typically we'll utilize the deltopectoral approach here. I think that's a better approach for me, especially if I have any problems intraoperatively, like humeral shaft fracture, or have to go back in the future for revision operation. This is more of a utilitarian approach. I think that as you start this operation, identify your landmarks, as we talked about with the lesser and greater tuberosity bicipital groove, and isolate the humeral head, and oftentimes it's floating. That's anatomic fracture. Remove that, and then you want to, as Pascal below has talked about in the past, properly tag your tuberosities at the tendon tuberosity interface to really have good control of them as you go for your glenoid exposure. And you want to have control of your tuberosities, my experience, prior to working on your glenoid side or putting any base plates or glenospheres in, because then you've obviously lost a lot of space, and now you're fighting yourself to get the exposure that you need. So it's pretty easy to get this all set up prior to going to the glenoid side. And then from there, it's stepwise fashion. Do the glenoid side. Oftentimes we'll put in my glenosphere, and then start to build the jigsaw puzzle back up, and using oftentimes a cemented stem, black and tan technique, as John Levy has described, for cement and auto/allograft bone, and then fixation of the tuberosities around your stem, and then cerclaging the humeral shaft to your tuberosities and stem as well to gain vertical and horizontal stability. Typically, I'm putting these in 30 degrees of retroversion for stability. And this is video from one of my partners, Luke Austin. And there's the destroyed biceps tendon at that point. Here's tagging sutures of the greater and lesser tuberosity to get control of those. And here's a free-floating anatomic head slam dunked in the axilla and just hanging out. This is an elderly patient with poor quality bone, high likelihood of failure in this situation. And you can see here, we have excellent exposure for our glenoid. This is probably the best exposure you'll ever have for glenoid insertion in a patient in these fracture situations. And depending on the system you use, prepare your glenoid and put in your peripheral screws, etc. And you want to be careful with these patients on the glenoid side as well, because oftentimes they are osteoporotic, and you want to make sure that you don't get too aggressive with your reaming, as sometimes you can over ream or even sometimes catch an edge and fracture your glenoid. Once you have your glenosphere in, you have your tuberosities tagged, and you're working on your humerus. And most of these cases, personally, I'm doing them in mostly elderly patients and they're osteoporotic. I don't want to go line to line fit. I'm doing a cementing technique and then passing sutures through the shaft, and then proceeding with my cementing, and then putting some allograft or autograft bone. Previously confirmed my version there, and then impacting the stem into place. You don't want to under reduce, but you don't want to also over reduce your tuberosities, and then you want to fix the tuberosities to the stem as well as to each other in the fashion that I showed previously. And oftentimes these patients really do great in their recovery pattern. I think that they recover a little bit differently than a cuff tear arthropathy, reverse shoulder arthroplasty, but not much differently in my experience recently. The thing you have to be careful about is you make sure you restore length, and sometimes you may need to get actually the contralateral side to see what the length was there. And again, we know that the top of the humeral head to the top of the pec major insertion is 5.6 centimeters, and you can extrapolate from that to assess where you are relative to the top of the reverse humeral component to have a secondary check for recreation of length of your humerus. We do know that over lengthening, especially by around an inch, can start to become a risk factor, as Walsh has shown us, for neurologic complications, brachial plexus injuries. So I have to be careful about that. As far as pearls, tuberosity healing is a major determinant of results, whether you're doing an RAF or an arthroplasty. And I think that It helps with arthroplasty to get the tuberosities to heal for stability and better function. In older patients, I'm going to lean more towards arthroplasty, especially if they have highly comminuted osteoporotic bone, but I will have multiple options available, and we'll talk to the patient about this. And sometimes it is a game time decision. And whatever you do, you want to think about revisability of what you choose and what the patient may have to go through if things don't work out the first time. So again, in summary, RSA for certain proximal humerus fractures in the elderly. I think they do get oftentimes more predictable function than a Hemi, and in some situations an ORIF. You have to think about the longevity of what you do in these patients and the cost effectiveness. And I think we need to still study this further. And this should be limited to surgeons who have a lot of experience treating proximal humerus fractures with various modalities such as ORIF and or arthroplasty. And I think that making the right choice the first time saves you and your patient a lot of frustration, as the anchor man would tell us. Thank you.
Thanks, Joe. That was a wonderful talk. Maybe I'll ask with a couple of questions from you directly now. First is hemiarthroplasty. Are we done with hemiarthroplasties? Is it fixed or reverse? Or do you think there are still roles out there for hemiarthroplasty in fractures?
I mean, I think that if you're taking care of high energy trauma in younger patients who really have dusted articular surfaces, I think there's still a role for hemiarthroplasties. And as my senior partner, Jerry Williams, will say, that a well-done hemiarthroplasty knocks the snot out of any reverse shoulder arthroplasty that he does for fracture. Now, not everyone is Jerry Williams, so I think you have to be careful, how you extrapolate that to your practice. I think that, again, one of the problems we see is trainees are not seeing hemiarthroplasties done much anymore for fracture, and to take that on in practice in your first 5-10 years, it's a dying art. So I think, yes, I think in a highly comminuted, high energy trauma center like Mike Gardner does at Stanford, I think that there's still a role for that. I think in my low energy trauma population, not as much anymore. And so I don't do it anywhere near as much as I did about 10, 15 years ago.
Mike and Eduardo, do you do hemiarthroplasties often in your practice, or is it gone out of fashion?
Not me. But that doesn't mean there's no indication. It's not a surgery I do.
Yeah, gotcha. Now, one other question I want to ask you, Joe, is...
let me interrupt you, Ali, because
yes,
I think that what happened with hemiarthroplasties, and I would agree with Joe, the problem with the hemi really begins with the fact that it's you have an intramedullary fixation, and it's very difficult to get your height, and it's very easy to make it either too high or too low, and then you got this big chink of metal in there, so the tuberosities don't heal. Now, it doesn't mean that in the future we will not have a hemiarthroplasty option that allows for tuberosity healing and that allows you for reconstruction of the joint, which may be what we need for the younger, more active patients in whom a reverse would be a bad option. So I would say don't get rid of the concept of hemiarthroplasty, but I don't use it the way it exists at this time. But I think we keep looking, we keep thinking outside the box.
Perfect. And just a question to the panel, those of you that do reverses, is how often are you making the decision on the table when you opened up the fracture and said, I can't fix this? Or is it a relatively pre-operative decision to use a reverse? Is there a situation where you go in when you say, I'm hoping to fix this, but then you find that you can't fix it? Or is it invariably a pre-operative decision that you are going to do a reverse? What's your experience, guys?
So for me, I would say it's about 10% of the time that I change my mind intraoperatively. But I have that option there because there's nothing as valuable as actually being able to palpate the bone and getting a sense of kind of the entire envelope of the patient. And so I think that's always important to have available. I'd hate for them to wake up with a procedure that I didn't talk to them about.
And Eduardo, yourself?
The same. There are minority of cases where you have to have both of the options available. You don't want to be unprepared, and you do want to tell the patient that they may need one or the other. So plan A and plan B, and you have them available. And that, of course, is for those fractures that are, they're going to be a challenge.
Fantastic. And I think the next question I want to ask is about head splits, right? So there's always this thing about head splits where residents are worried about head splits means that you should replace it and so on. But do you see head splits as different kinds of fractures? Are there different kinds of head splits? Are there ones that you would fix? Are there ones that you would definitely say we can't fix this?
Yeah, I mean, I think so. First thing is that head splits are no longer a knee-jerk arthroplasty situation. Certainly in younger patients, we can reduce and fix head split type patterns, and they can do quite well. The other thing is, as we've gotten more experience with CT scans and stuff, we'll see. I think it's Eduardo, and I fully agree, was like the lesser tuberosity fragment is more than that, right? It's the bicipital groove, it's part of the greater, and it's part of the articular surface too. Sometimes it's a large part of the articular surface. So I think that erroneously kind of gets called a head split because it is an intra-articular kind of fracture, but it certainly doesn't behave like that. So that's just another little caveat. So yeah, I think many head splitting type patterns are fixable.
And certainly that's my experience as well in the younger high energy trauma. We fix most of them and they tend to do well. Joe and Eduardo, your experience on this, any comments on that?
No, I think Michael hit it right on the nail. You sometimes see those that look like, you see the double outline of the head, but you look at your CT scan and it's not as bad. And then the other thing is that when you open up, on the head splits especially, I tend to look at the cancellous bone to see if there's bleeding. And for younger patients, if there's any bleeding of that head component, I go ahead and fix it.
Perfect. And Joe, your experience on those?
Yeah, I mean, it's funny. When I was a fellow, it was one of the relative indications for hemiarthroplasty was, this head split injury. So it was a knee-jerk reaction. Now, no way. I mean, I try to fix the majority of them. Again, unless it's like, 4 or 5 fragments, and that situation is kind of foolish. But I think a lot of them do quite well. Some of them get some arthritic changes, but a lot of them are still asymptomatic even with the arthritic changes.
And that's probably one of the most important lessons from this talk today, that that was exactly what was 15 years ago, 20 years ago. It was like head split is arthroplasty. And now all of us here are trying to achieve a stable fixation and finding out that actually most of them do pretty well. So if that's a good lesson, I think, for the people watching there. Is there anything else you would like to ask? We've taken up a lot of your time. We've answered most of the questions. Is there anything in particular that you feel like we haven't covered or have a strong feeling on these topics that you would like to share?
Not for me. Yeah, I think we covered a lot of ground. Nothing kind of outstanding major that I think has been omitted to this point.
Yeah, outstanding.
Fantastic.
Michael, can I ask you?
Yes,
Michael, can I ask you a question? For the fibulas, because I don't have experience with the fibulas strut, but do you have when you revise them, how tough is it to revise, or I mean, when you're putting them in, are you worried about revising them in the future?
Yep, that's a good question. That came up in the Q&A. So the deal with the fibula and then revision to reverse is, if you pot a fibula into the intramedullary canal, it's extremely hard to drill, to ream, and because it's just this thick cortical bone. There's actually a pretty interesting published technique. I think Andy Chu from UT Houston published in JOT. He'll open up the diaphysis of the fibula and actually cement a stem into the fibula as a workaround. But as I was saying in the Q&A, I think there's very few fracture patterns that benefit from a fibula that's sticking straight down the canal and up into the lateral head. So I really don't put in fibulas that way. I have it short and tilted. And so when it's oblique to the shaft, you can drill through that pretty easily. But certainly a long fibula that's then well healed is a pain. Yep, it's problematic.
Guys, that was fantastic. I know some of you have other commitments starting in a few minutes, so I don't want to hold you back. I would like to thank Joe, Mike, and Eduardo for joining us and giving up your precious time to give this phenomenal talk. And again, of course, Ramon and Carla, thank you for organizing this through OrthoHub. There has been a big audience attending. So without further ado, guys, have a good night and thank you again.